Good afternoon, everyone. My name is Sharon Rounds, and I am a professor of medicine at Brown and the program director for Advance-CTR. This year, we're very pleased to be presenting a monthly seminar series on translational research with a variety of distinguished clinical and translational research scientists from throughout the state. Today, we're very, very pleased to have our friend Kerry LaPlante speak with us on her work. Kerry is a infectious disease pharmacotherapy expert. She is a professor of pharmacy at the University of Rhode Island and also chair of the Department of Pharmacy Practice at the University of Rhode Island College of Pharmacy. She is an adjunct professor of medicine at the Warren Alpert Medical School as well, and fellowship and research program director of the Rhode Island Infectious Diseases Research Program at the VA Providence Healthcare System. Kerry is well known for her expertise in antibiotic therapy, including her work on biofilm-associated infections, the use of combination therapy, and also has had important experience in establishing antimicrobial stewardship programs to prevent the development of resistance among hospitalized and as well as outpatients in the acute care setting. I had the pleasure of working with Carrie a few years ago when she was establishing the antibiotic stewardship program at the VA Providence. And this was a great undertaking. And in fact, it was the first antibiotic stewardship program in the state of Rhode Island, and one of the first in the nation. And it's served as a model for antibiotic stewardship programs, not only in the VA nationally, but also in the non-federal healthcare settings. So this is a very, very important contribution to clinical care, in addition to her terrific research. Kerry is past president of the Society of Infectious Diseases Pharmacists Group. And needless to say, her research has been continuously funded over the years by the NIH, the Department of Veterans Affairs, as well as important investigator-initiated research trials. So today, Kerry is going to be talking to us about the treatment and prevention of antimicrobial resistant infections. It takes a village. A couple of housekeeping notes. Please enter your questions into the chat and we'll address them at the end of her talk. And I just want to note that next month we'll have, on November 10th, we'll have Mukesh Jain, the Dean of the Warren Alpert Medical School, presenting his work on new insights into vascular thrombosis. So without further ado, I'll hand it over to Dr. LaPlante, and thank you once again, Kerry, for joining us today.
Thank you, Sharon, my pleasure. And thank you for that very gracious introduction. So, when Sharon first asked me to present at this distinguished seminar, of course, I was honored. I said, of course, I'm happy to help out and show off all the work we're doing at Rhode Island in collaboration with the VA. And really, it's been a nice journey the past month putting this together as a reflection of my career. And the highlighting it takes a village really is meaningful because I've had so many mentors and so many collaborations along the way that have really helped me within my research career. So for those of you who haven't been on our beautiful campus at URI, this is our medicinal gardens. It's right behind me. I have this fantastic view. My office is up here in the corner. So you're seeing it from an office, from an opposite side. But, if you're ever down in South County, please say hi. I have to share that none of this and the fantastic career that I have had in research would have happened without my close collaborations with the research office at the Providence VA. That is where my research program exists in Building 7, and the support from Bob Swift over the years, and also Gareth Chowdhury. So today I'm going to go through and just share with you a journey, my journey as a pharmacist scientist, and go through some of the bench research and advice on developing teams, working together with other leaders, and while reflecting on my science. So, my career path is not one of a traditional scientist. I have my undergrad in biology from Canisius in Buffalo. I then got my BS in pharmaceutical sciences at Wayne State. I got my doctor of pharmacy degree at Wayne State. And during that, I did my training at Henry Ford Hospital in a longitudinal advanced pharmacy practice experience. It was during that experience, it was actually July of 2001, that I had my first patient interaction. It was a cystic fibrosis patient. She just had a double lung transplant. She had Burkholder and Pseudomonas, very complex infection, biofilm. And as an intern, I was fully in charge of her antimicrobials and her combination therapy, and it was challenging. And that really kind of set off my passion for infectious diseases. I then stayed in Detroit. I did a fellowship in pharmacodynamics at the Anti-Infective Research Lab in Detroit, Michigan, and went on and have had a very fulfilling career here in Rhode Island, and because of all the mentorship I've had. So my theme here is, it takes a village, and it's very reflective of the amazing and very complex world of infectious diseases. There's a lot of collaboration, and a quote I read one time is, bacteria work together because it makes a difference. And that is exactly what happens in the research world of infectious diseases. So all my training as a pharmacist scientist is really framed in pharmacology, right? Not only what happens, what the drug does to the patient, how they metabolize the drug, the pharmacokinetics and pharmacodynamics. What I always say, and I share with my pharmacy students and my fellows, is that pharmacy is hard enough in understanding medication efficacy and safety, but when it comes to ID, it's even more complex because we not only have the patient and the drug, but we also have the organism, whether it's a virus or a fungus or a bacteria or a parasite, what that organism does to the patient, the immune response. And we also have concerns regarding susceptibility. Is there resistance to the bacteria or fungus or virus? What those drugs do and how they kill those organisms. So again, highlighting how complex infectious diseases is and exactly why I've fallen in love with them. So during my fellowship training, I took a lot of the work that I've done at Wayne State and in the Anti-Infective Research Lab and PK/PD modeling, and really brought it to Rhode Island, and have been able to evolve and augment my work through the collaborations that I'm going to chat about today. In our lab, we do a lot of PK/PD 1-compartment modeling, 2-compartment, measuring different volumes of distribution. We have our simulated endocardial vegetation model or biofilm reactor model. We've done antibiotic lock therapy, and we do the basic, checkerboard or FIC index, the time kills, disk diffusion assays, and all the MIC, MDC work. And this is what I brought, to Rhode Island from my training at Wayne State. So those models continue to be pivotal in my bench research program. And it's in working with these different models and bringing and combining some of the important clinical questions from both our PhD and my physician colleagues here in Rhode Island that allowed us to, I feel, have a deeper understanding of how these antibacterials work and to offer more meaningful information to our clinicians. So these are pictures here of two of the models. On the left here hand side, it's our 2-compartment simulated endocardial vegetation model. You see the little clot here in the corner. And then on the right-hand side, it's our 1-compartment model, just simulating patient elimination half-life. We can look at combination therapy. And after I was in the Providence VA for a few years, I realized that the infancy of these in vitro pharmacodynamic modelings actually started in Rhode Island back in the 80s. Dr. Blazer at Roger Williams Medical Center in the Cancer Institute was taking a lot of the research that was being done there and bringing it into the antimicrobial world. So it's, I think, very ironic that, this was the model that I was trained with, what a lot of us in antimicrobial pharmacology do, but, they really began right across the street from my lab at Roger Williams Hospital in the 80s. So the first 5 years of my research program, you're trying to be successful, tenure, get funding. Right after I made tenure, and had a family, had young children, thought, how do I expand a little bit more? Because I can't do this alone. There's the in vitro program, which is, my passion and my expertise. I had a strong clinical foundation, but something was definitely missing. And I remember, as I do every year in December, I kind of write down my goals and what I want to accomplish that following year, write them all down, do that Warren Buffett model where circle 1 or 2 of them. And I remember doing this and writing down that I need more help with genomics. I need more help with outcomes and predictors models, understanding the risk factors. And the goal that I had at the time was taking all the in vitro knowledge and expertise I had and, the thousands of bacteria that I've been collecting from across the country, colleagues, different cases, Department of Health, and also patients at the Providence VA. How do I mirror that with outcomes and risk factors and really expand my program? I was feeling a little insecure in doing it because I didn't have the training in the outcomes and predictors and genomics, but, was reassured by my mentors and colleagues at the time that you don't have to have that expertise, but you need to work with people and develop relationships and friendships and let them do that and work together in true collaboration. So it was about 2008, 2009 when our my in vitro program expanded and evolved and became more of a full program that spanned not only the antimicrobial pharmacology, but this is our current org chart, but an outcomes and pharmacoepidemiology division led by Aisling Caffrey, who has her master's degree and PhD and is a fabulous methodologist. And then a few years later expanded to antimicrobial stewardship in 2012 and implementation science. We made Haley a director. She's a Pharm.D PhD, just got her PhD at Brown a few years ago. And she leads all of our outreach, stewardship, and implementation work at the VA. And then worked with and continue to work with Kevin McConaughey, who's doing clinical trials and vaccine work. It's all supported by our amazing lab program coordinator, Katie, our data analyst, Vershali, and the team of fellows, postdocs, some are undergraduate research students from the COBRE, and some physicians that work in our lab. So really honored to have had the opportunity to work with so many amazing people and expand, my in vitro program into something more expansive and more meaningful for our patients. So the scientific portion of this talk today, it was tough to just pick one, but my true passion and heart is in my bench research with gram-positive bacteria. So Staphylococcus species, whether it be Staphylococcus aureus or Staphylococcus epidermidis, they're big biofilm producing organisms. That work and early work I'll share with Len Mermel, a great mentor and friend, evolved in working with Lou Rice and Enterococcus faecalis, international expert in that area. And then I'll end with some of the work that I've been honored to do on the clinical guidelines for C. diff. So first, a slide I always like to share. My first, love and passion is in Staphylococcus aureus and all things staph. I think, as most of you know, this bacteria has developed resistance to nearly every antibiotic used to treat it. It produces toxins, it produces biofilms as a form of virulence, and it transiently or persistently colonizes the skin. And we have done a lot of work in all of these different buckets of Staph aureus. That passion began not only from that patient I treated who had cystic fibrosis back in the day at Henry Ford Hospital, but this is a paper that I read from Rodney Donlin. It was 2002. It was right after I accepted the position at the University of Rhode Island College of Pharmacy. And he published this paper. He's at the CDC talking about, microbial life on surfaces and biofilms. And I'm a very visual person, and really just came, slightly obsessed with how I could not only combine my knowledge and passion about pharmacodynamic parameters and how different antibiotics kill, and how this works in biofilm and antimicrobial resistance. We know antimicrobial resistance is a problem, but biofilm and virulence is another form of resistance, more of an intrinsic resistance that in the pharmacy world, and when it came to typical how antibiotics work, there was not a lot of research, and I would argue there's still not a lot of research being done to combat it. And I quote, a mentor from 10 years ago who said, Carrie, I used to do biofilm work. And I said, well, why did you stop? And he said, because it was too hard. And I remind our fellows of that all the time. It is very difficult to kill and penetrate these glue-like substances that these bacteria hide in. So just to give, some full insight for those of you who are not familiar in the antimicrobial world, these biofilms exist. They are these glue-like EPS extrapolymatrix substance that bacteria hide in and create to protect themselves not only from antimicrobials, but also our immune system when they exist in bodies, our own patients. And when we talk about biofilms and the treatment of biofilms, they're really broken down in different stages. Stage 1 here is attachment. It's when these planktonic bacteria that are free floating in the environment or in the bloodstream of a patient or in the water, they attach. And all of the work in infectious diseases, all the susceptibility reports that we see clinically from our micro labs come from these kind of free floating cells. And when we decide and get the MIC reports of what's susceptible and what's resistant, it's the bacteria that exist in this state. It's that second layer, the monolayer, where the bacteria start attaching to the surface. They have these ability to stick, especially Staphylococcus and Pseudomonas, to medical devices or tissues. And they're kind of organizing themselves and become a little bit more difficult to treat. But with good science and material science engineering, they've been able to alter catheters in a lot of our devices to make those bacteria not stick. But our bodies tend to coat over these catheters and medical devices. Microcolonies will continue to evolve. Bacteria communicate through quorum sensing. They decide together to all create biofilm, to all produce different communication strategies. And oftentimes, and as we see in persistent chronic high inocula infections, we have this stage 4 mature biofilm, which you see here on the right-hand side of your screen. And within these mature stage 4 or 5 biofilms, usually you'll see this after 24 hours. They have persister cells, they're difficult to kill. And this is where, I can become a bit obsessive and focus a lot of our research. For the clinicians in the audience, you're familiar with these already because you see a lot of device-related infections. Our work has been in looking at endotracheal tubes, central venous catheters, peripheral vascular catheters, and more recently, orthopedic implants and prosthetic joints. Staph epi likes to stick a little bit more to those plastics. Staph aureus does too, but we see these Staph aureus infections mostly in infective endocarditis, many others, but the model here that we use is infective endocarditis. So that brings me to all the other intrinsic type of resistance, separate from all the enzymes and porin changes and all the other forms of antimicrobial resistance. Our focus is on the high inoculum, the biofilms, the virulence, the abscesses that we see, and the tolerance and the persister cells in these established biofilms. And certainly an unmet research need. These are pictures that we have taken, and as I share with my students, sometimes I just look at them and am mesmerized by how these bacteria, these very, very small colonies of bacteria, stick so quickly, persist, and continue to invade. And I'll show in a little bit some of the clinical work we've done on how they remain stealth in the body. And because of that biofilm and that kind of protective fortress, as we call it, they go unseen by the immune system. Our immune system sometimes doesn't recognize them, and we won't mount an immune response because they do a very good job at hiding. They're stealth like that, but also this makes it very difficult to rid and get rid of these chronic infections. So original work that I did when I was a postdoc fellow was just modeling these simulated endocardial vegetations. And we look at moderate inocula that we see in a body, a typical infection, and the concentrations we use to kind of simulate that infection in the microlab is around 5.5 log base 10 colony forming units per ml if it's in the blood, per gram if it's in kind of tissue. And so we modeled this moderate inocula, both in methicillin susceptible Staph aureus and Mrsa. This was, again, our simulated endocardial vegetation model. And as we typically see in our MSSA, we have our log base 10 CFUs per gram on the y-axis. We see our growth control as expected. We modeled linezolid, nafcillin, daptomycin, and vancomycin. Linezolid, we see the typical bacterial static activity as we do with ribosomal active antimicrobials. And then we started seeing the typical bacterial cytal kill with beta-lactams. We modeled nafcillin, daptomycin, it was a newer antimicrobial agent at the time, and vancomycin. Mrsa, we saw the same thing. Obviously, we didn't use beta-lactams. This was typical. This was our control. Everything grew and killed as we expected. But we wanted to kind of, here's a picture of our vegetation there. We wanted to model it in a high inocula infection. That high inocula, as we see in an infective endocardial mass or vegetation, where there's oftentimes biofilms or persistent cells that are kind of in this stationary phase. We brought the inoculum up to 9.5 log base 10 CFUs per gram in this kind of clot model. Growth control grew as expected. We looked at gentamicin because, usually gentamicin in combination with another antimicrobial agent is standard of care for infective endocarditis. Gent didn't do anything as it wouldn't monotherapy. Our nafcillin here, beta-lactam, standard of care for an MSSA type infective endocarditis treatment, no kill. Very interesting. I ran this again and again. Moved on, ran Vanco Gent. Jen helped Vanco a little bit, ran linezolid, still same kind of reaction. Ran nafcillin in combination with Gent, saw a better kill. And then, of course, the very impressive kill we see with daptomycin, especially in vitro, which killed to our limit of detection, daptomycin alone or dapto in combination with Gent. We started calling our colleagues across the country. This was in Detroit at the time, trying to figure out, no matter how many times I ran this model, about 16 times, these models cost about $1,000 each to run. My PI was not very happy with me at the time, could not get the data to look the way we expected it to look. And through many conversations, realized that nafcillin, it's a beta-lactam. In a high inoculum type model, you're not going, the bacteria is not going to be exposing penicillin binding proteins, which is the site of action for our beta-lactam antimicrobials. And when bacteria are in stationary persistent phases, whether they're in a high inoculum or a biofilm, these antibiotics are not going to be able to kill. It wasn't until we used combination therapy with gentamicin that we saw significant kill. This study, one of my most cited work, and it began the framework and the trajectory of the rest of my career, trying to understand the role of combination therapy in Staph aureus. So this is where I kind of divide my audience, if I'm talking to more of a scientific PhD audience, this makes sense to them. This is mechanistically, it wouldn't make sense. If I'm talking to a pure clinical audience, it's a different conversation because the stewards out there will say, I'm not going to use combination therapy and expose my patients to multiple antibiotics when there's no randomized controlled trials that really show the difference. And I'll share some of these trials that have been out there. So when I first came to Rhode Island, I had the honor early in my career to be taken under the wing of the good Dr. Len Mermel, who at the time was the lead author in writing the clinical practice guidelines for the diagnosis and management of catheter-related infections. Here in Brown, it was an honor to work with him. And we started to do a lot of work together in those early days. And it was a big part of my tenure and promotion. His mentorship, meant the world to me. He had and has this very unique ability to ask very simple questions, look at them clinically, and immediately translate those to an unmet clinical need in a very simple type of way. So in those early years, while at the Providence VA and working with Len, we modeled pretty much every type of antibiotic lock therapy, which is a therapy used. If a patient has a catheter-related bloodstream infection or dialysis patient, you can't remove that catheter. Source control is obviously what you want to do, but a lot of times we can't. And what type of antibiotic lock therapies, which are not approved by the FDA by any means, but how do we salvage these catheters? We looked at Vanco and Gent and Daptomycin, Tigacycline, Telavancin. We then realized that these antibiotics alone, and they're not just used alone, but there's an augmented synergistic effect or an antagonistic effect when we use them in combination with other antiseptics, such as alcohol, such as citrate, when we combine them with heparin. As we looked further and further, whether we used drug powder from Sigma or product from the pharmacy, we would get different results. It was a bit frustrating and mind-boggling, but we knew that work needed to be done. And we needed to do a better job understanding not only the biological activity, just the cell death, bacterial cell death of these antibiotics, but the compatibility of the heparin or the citrate that we're combining, so there's not a clot, and you need that anticoagulant in the lock therapy, and also looking at the chemical stability of the agents. So many papers came from that work. Very proud of them. The initial work with daptomycin and vancomycin, the talking point from that is when we're reconstituting daptomycin in a clinical setting, that we need to reconstitute it with lactated ringers. As we know, daptomycin needs calcium to be active. And if you just reconstitute daptomycin with normal saline for an antibiotic lock solution, where there is no calcium because it's not used systemically, you're not going to get the same effect. We looked at linezolid, we looked at vancomycin, we looked at the stability of heparin and citrate. And in some of the most well-cited work was the work we did on the ethanol lock solutions, and how we found that using these 70% ethanol lock solutions, they increased biofilm formation in Staph aureus. At the time, this was standard of care, especially in the pediatric community, at trying to be an antiseptic to sterilize catheters. But in looking at many of the different bacteria, and this is an SEM picture, that's only one moment in time and one quick scan, but we were consistently seeing that when we would lock a normal saline lock, which is here on the right-hand side of the screen, these bacteria didn't necessarily grow biofilm. They stayed in stationary phase, but the minute we would expose them to ethanol or isopropyl alcohol, any gradient of a lock solution, those bacteria, especially the Staph epi, would instantly form biofilm. And that work has moved forward to change clinical practice and kind of give a second look at using ethanol lock solutions in patients. One of my favorite papers, and I think all of the researchers have this, it's that paper that you think, I'm going to be famous from this work. This is my life's work, all summarized in one paper. And this is the culmination of my in vitro work and all the bacteria that we had in the lab, screening them for biofilm formation, working with Emily Martin, a PhD out in Michigan, who did a lot of the genomics work, and then working with my colleague, Aisling Caffrey and Vershali, our statistician, to look at risk factors and predictors. And what we found, there was a lot of information in this paper, but some of the foundational work, not only we were able to predict certain Staph aureus bacteria that harbored SPA type T008, were more likely to be biofilm producing MRSA isolates. That was huge and hadn't been really identified at that point. But also confirm what we thought, is that patients with strong biofilm producing MRSA were significantly more likely to be readmitted to the hospital at 90 days, but of interest, had decreased mortality as compared to our non-biofilm producing organisms. And I think that goes back, and what we offered clinically is, our patients with strong biofilm forming MRSA were less likely to die at 90 days, but 5 times more likely to be readmitted. So readmitted from a chronic infection. But what we kind of postulated here is that these biofilm forming Staph aureus are stealth. They hide out, the immune system doesn't notice them, and sometimes some bacteria and persister cells will seed out in a planktonic type of stage and cause some infection, but these patients were less likely to die from our work, or from the work that we saw. Our work evolved in looking at more of a microscopy picture in how do different antibiotics penetrate in a formed biofilm. Again, all of our work is really in these stage 4 biofilms, and I would caution others who look at biofilm, because what I usually see in the literature is most people will take these biofilm forming bacteria, but they're doing all of their research in a stage 1 type biofilm. So you take a bacteria that can form biofilm, but you're looking at it more in a planktonic phase. I would encourage all of the biofilm researchers out there to ensure that you're taking your biofilm forming bacteria and certainly having them in that, modeling it, what we're seeing clinically in that stage 4 biofilm. The downside of this is that you're not going to see a lot of good results. So it's much easier to model a stage 1 biofilm forming bacteria. But we wanted to look a little further and try to get a better understanding of why we're not seeing as good outcomes clinically when we use a vancomycin alone or vancomycin with rifampin. So some of this work, this was done early days of COVID. It was just, I think it's under revisions at DMID right now, but looking at antimicrobial penetration and bioavailability of both, we have vancomycin and rifampin and daptomycin. The work we show here is the antibiotic penetration and the bioavailability. So what we see in this slide is antimicrobial penetration in a 24-hour stable biofilm. Our high biofilm isolate structure was compared to a non-biofilm mutant, the kind of a wild type. And in our high biofilm forming methicillin-resistant Staph aureus, we see the typical peaks and valleys of a stable biofilm. Our peak was at 111 micrometers. Our valley is about 15, typical what we see. Our base was a polyurethane coupon to model what we see in a typical prosthetic and device infection. And then our low attaching biofilm Mrsa, the height was only 5 micrometers. So those were our initial controls. And what we found, similar to what others have, is that in a stable form biofilm, we looked, at different time points up to 60 minutes, is this fluorescent vancomycin will do a very nice job coating on top of the biofilm and binding, but quite frankly, it does not penetrate into a form biofilm. We looked at bioavailability and we did FRAP, the fluorescence and photo bleaching with vancomycin in combination with rifampin, which, by the way, was standard of care for an MRSE or MRSA infection per the prosthetic joint infection guidelines, and looked at both the lower, middle, and upper layers, exposing quick fluorescence exposure, and looking that once again, very low penetration of both vancomycin alone or in combination with rifampin. And this really correlates to what we're seeing clinically and gave us a little more momentum and incentives to look further in what antibiotics we can use to treat these biofilm forming infections. As our work progresses, double coverage in gram-positive bacteria is controversial. There's a lot of debates in the pharmacy community on when you use double coverage for staph and when you don't. And quite frankly, it's because there's not a lot of clinical trials out there saying that you should. A common reflection I make when I'm in these conversations at national meetings, and this is a slide I've used many times, is that if you think back in other areas of infectious diseases like HIV and tuberculosis, standard therapy is multiple medications, HIV, heart therapy, 2 to 4 medications, TB, very persistent, slow growing type of a bacterium, standard treatment, 3 to 4 medications. And why is that? Well, not only it's because of a growth from a tuberculosis, it's a slow growing and a persistent type of state, and an HIV is preventing resistance. And we really haven't done a good job proving this in our antimicrobial space. And there is a history of antimicrobial combination therapy out there. We use Bactrim, which is trimethoprim sulfamethoxazole. We've used quinupristin, dalfapristin, which are semi-synthetic streptogramins. And using these two antibiotics together certainly demonstrates synergy. You can take bacterial static agents in combination. You have bactericidal activity when used together. And then also from the resistance standpoint and overcoming resistance, beta-lactams and the beta-lactamase inhibitors, because beta-lactamase inhibitors are oftentimes beta-lactam antibiotics, and using those in combination together will often show synergy and obviously have different mechanisms of action. There is a downside of combination therapy, and sometimes we see antagonism. This is some work we did in 2007. If some of you recall some of the catheter-related bloodstream bacteremia infection work that was done by Pfizer, they had linezolid, but in 2007, the FDA issued a safety alert regarding the use of linezolid for catheter-related bloodstream infections, noting that in the clinical trials, there were higher mortality rates in patients treated with linezolid who were infected with gram-negative organisms, which doesn't make sense because you think, well, linezolid is only a gram-positive bacteria. How does that really kind of get unpacked? So, the linezolid and the infectious disease kind of gurus know that, linezolid does have some gram-negative activity. We don't talk about it. We don't use it for gram-negatives. But if you combine it with a beta-lactam antibiotic and you open up that cell wall, linezolid gets in much better and has its activity on the ribosomes in combination with a cell wall active agent like a beta-lactam. And what we did is model that to look for synergy or to look for antagonism. And what we found in these models is that linezolid in combination with a beta-lactam against E. coli was antagonistic. So we concluded, on a very high level, that there are significant yet underappreciated interactions that occur between our gram-positive and our gram-negative spectrum antibacterials, and there really isn't a lot of research done in that area. And this made sense to us because in the 50s, for those of you in the ID space know, combination therapy in serious streptococcal infections, we were seeing worse outcomes in patients that were treated with benzyl penicillin plus chlorotetracycline as opposed to the benzyl penicillins. In these early clinical trials, we saw that when rapid essential kill from a beta-lactam may be necessary, perhaps bringing in a static agent like a tetracycline may delay that bactericidal kill. So I'm kind of talking out of both sides of my mouth, and somewhere in some areas, we really need to lean into combination therapy where we can have more synergy and bactericidal kill, but not in a result of causing antagonism. And I still think that this world, there's a lot more work that we can do in dissecting both of these. So as our research continued and looking at different combinations of antimicrobial therapies, The standard in most of the Infectious Disease Society of America guidelines is vancomycin in combination with one other antibiotic for MRSA infections, because 30 years of using vancomycin, we're still seeing in serious high inocula infections maybe a 50-50 success rate. 50% mortality is still high in infective endocarditis and bacteremia, especially when there's endovascular foci of infection. And why is that? Well, we know that we've seen in our own work, vancomycin, poor tissue and intracellular penetration. It lacks activity against organisms in a biofilm. It has slow bacterial cytal activity, doesn't do anything for toxin production if it's a virulent type of bacteria. And, although we don't see a lot of resistance, there's a lot of tolerance that can develop. And also in the ID space, we know there's a lot of various methodology, whether it's the checkerboard synergy test, the time kill curves, or these more sophisticated in vitro models that we use. And sometimes we can't get consistency across the different methods. So some of the earlier work that was done by George Sekoulis, another friend and colleague with, that I've had the honor to work with and publish a lot of trials. He was the first, it was September 2009, to really highlight that you could use a anti-staphylococcal beta-lactam, so beta-lactam activity in combination with daptomycin or sometimes vancomycin in MRSA. So, our clinical community would think, wow, how are we using a beta-lactam in MRSA? And how is that synergizing and increasing daptomycin's activity? Well, he was able to dissect that as with some of the work that we've done in our lab, and just understanding the seesaw effect of how different antibiotics work together. And what we saw with both vancomycin and daptomycin in combination with the beta-lactam in MRSA, when the MICs, the minimum inhibitory concentration of these beta-lactams decrease, in glycopeptides like vancomycin and lipopeptides like daptomycin, there's this seesaw effect. So as they go up for daptomycin and vancomycin, they go down for beta-lactam. So showing that there's this enhanced kill and synergy. And as everybody in the ID kind of basic science space is like, we see this in the lab, but does this really apply to clinical work? So more mechanistic work was done. The proposed mechanism, why we were seeing this in vancomycin and beta-lactam synergy with MRSA, is that we do see in the lab, and we can model this, is that repeated exposure of vancomycin, long-term vancomycin use is maybe what you would see in a chronic infection. The vancomycin exposure increases that cell wall thickness. And then this leads to increased target sites for vancomycin, ultimately reducing the effectiveness of vancomycin. When you have beta-lactam exposures, those thin those cell walls, and vancomycin gets its activity back. Proposed mechanism for daptomycin and beta-lactam synergy in MRSA, a little bit different. Daptomycin, as we know, it's charged. It's a peptide antimicrobial agent, and once in contact with the cytoplasmic membrane on the cell wall, daptomycin disrupts that membrane, causes a rapid release of electrolytes, potassium, calcium, sodium from the cytoplasmic membrane, leading to depolarization. But exposure to the beta-lactam increases that negative charge on the cell surface, leading to an increase in daptomycin's binding and ultimately improve bacterial cytal activity. Well, this sounds great. This is all work that we saw in the lab, lots of conversation at the ID meetings, but there were no randomized clinical trials really looking at this. So far, there's been 3 big trials, and I'll briefly talk about them. The first one came out of the Australian group, the famous CAMERA-1 trial in 2015, looking at a combination of vanco and beta-lactam therapy for MRSA. The big talking points, they ended the trial early. There were several limitations. They didn't dose adjust for vancomycin based on AUC dosing. The timing of the blood cultures weren't standardized. This was an open label, multi-center trial. and they concluded that there was no difference in mortality. But they knew they needed to do more work. They expanded that work to CAMERA 2, which was a large international clinical trial in 2020, at the same time that we were doing our trial, looking at the same information. Ours was unfunded, but this was an open label, parallel group, randomized one-on-one trial across Australia, New Zealand, Singapore, and Israel, looking at vanco or daptomycin. Also stopped early because they were seeing increased risk of acute kidney injury in the interventional group. And at that point, when they stopped early, there was no significant difference in bacteremia, relapse, or mortality. Our group was a small unfunded work. Trial concluded in 2017. We published it in May 2019. Really wanted to look, we focused it. We didn't include a daptomycin combination arm because we knew we would see more toxicity, but we really just looked at the clinical data on daptomycin plus ceftaroline, which is a beta-lactam that does have MRSA activity, and clinicians would probably feel a little bit better using an anti-MRSA agent against MRSA in combination with daptomycin. And we had 40 patients with MRSA bacteremia. They either received standard of care vanco, serum concentrations were monitored, or daptomycin, or they received daptomycin along with ceftaroline. Our findings too are the study was halted early, but for a different reason, not because of safety or toxicity, but because there was a significant increase in mortality in the monotherapy group compared to the combination therapy. So just to dissect this a little bit further, ours was also an open label randomized prospective study. It was done in 3 sites, 2 in California and Henry Ford Hospital in Detroit. We only enrolled 40 patients. We had a good handle on the vancomycin monotherapy. We were monitoring the serum trough concentrations. We were using more aggressive daptomycin dosing. And when we looked at it, and this is kind of the key finding here, and why we decided to stop the study early, and the daptomycin plus ceftaroline arm, the combination arm for this trial, we had 0 deaths. These patients were sicker. The slide here. In the combination arm, they were more likely to have stroke, liver disease, chronic lung disease, and cancer. Yet there was a 0 mortality rate in the combination arm, as opposed to the monotherapy arm, primarily with vancomycin, where we were seeing a 26% mortality. 6 of these patients in this arm died, and we felt ethically we needed to stop that trial. So again, this is not the randomized controlled trial we would all love to see. That work still continues to be done, but really it gave us more incentive and momentum on how important it is to look at combination therapy to do better for our patients. And these were in endovascular device type high inoculum infections. So, at the end, I'll summarize a little bit more of the work I've done with Enterococcus and other gram-positive bacteria, another very drug-resistant bacteria. One thing we know about Enterococcus is combination therapy is the standard of care. We know Enterococcus demonstrate intrinsic resistance to antibiotics, all the cephalosporins, some aminoglycosides, Clinda and Bactrim, and they have the ability to develop high-level aminoglycoside resistance and also vancomycin resistance with VRE. A paper I published with Lou Rice and several other colleagues, very well-cited work that from Clinical Infectious Diseases and Cesar Arias in Houston. Both Lou and Cesar are kind of the international experts on enterococcal infections. We dissected the treatment of serious enterococcal infections and the role of combination therapy. My fellow dissected the literature, did a fantastic job doing that, and really dug deep into trying to understand mechanistically why there is this synergy with a combination therapy approach, with whether it be aminoglycosides or beta-lactams or a dual beta-lactam therapy. So, just to dissect that a little bit more, we know that, and it may seem odd to be using 2 beta-lactam agents, both an ampicillin and a ceftriaxone in an enterococcal type infections. But as most of us know, that cephalosporins in the ID community, cephalosporins preferentially bind to penicillin binding protein 2 and 3. and they disable the cross-link, the peptidoglycan chains. They work well, but there are not a lot of PBPs 2s and 3s in Enterococcus. But in an Enterococcus faecalis cell wall, ampicillin preferentially binds to penicillin binding protein 4/5. This leads to a upregulation of penicillin binding protein 2 and 3, which now the cephalosporin can bind. This results in 100% saturation of penicillin binding proteins 2, 3, 4, and 5. Lou Rice and the team, his team with Monica and Charlene, we've continued to do a lot of work looking at different beta-lactam combinations to treat these Enterococcus infections. One paper that I put in here, is just come out at AAC this month, and that's looking at meropenem plus septerylene in high inoculum Enterococcus faecalis infections. Moving lastly here to C. diff, the third gram-positive bacteria that I've worked with over the years. This is more outcomes-based. We know that C. diff, it's designated by the CDC as an urgent global threat. It spans all areas of healthcare. When hospitals do not do a great job, they are hacked with 1% of their CMS budget is cut. They are preventable, and we need to do better for our patients. We have a lot of risk factors for C. diff infection. And as some of us know, that Rhode Island is one of the worst in the country for C. diff laboratory reported infections. We believe, and at the Department of Health, it's because for many years we were just doing a one-step PCR test, and we felt that it was, we were detecting a lot more because we were only using PCR methodology. But we get on national news. Senator Whitehouse is always concerned at the Department of Health when this literature comes out. And we've dissected a lot of this and have done a lot of educational campaigns at the Department of Health, kind of doing a better job on how we need to implement these two-step tests across Rhode Island. And right now, all but one hospital in the state is doing the all of them are doing the two-step test except for one hospital in Rhode Island. So we've made significant headway. Some of the outcomes work I've done with Haley and Ashling are the predictors of mortality across the national VA healthcare system and C. diff infection, finding that age and antibiotic use, respiratory failure, and nutritional deficiencies are more predictive of worse outcomes. And also some interesting work on when can you use metronidazole to treat C. diff, because the IDSA guidelines came out saying you should not, but we found that if a patient's less than 65, it's an initial and it's a mild C. diff infection, that there were no difference using metronidazole or vancomycin. And with this work, one of the honors of my career as a clinician, separate of my work as a scientist, is having the honor to serve on the American College of Gastroenterology clinical guidelines for the prevention, diagnosis, and treatment of C. diff. And that's because also here in Rhode Island, we have Colleen Kelly, who is a gastroenterologist, an amazing clinician and researcher. She led this work, and probably one of, during COVID, a lot of late nights putting these guidelines together, and, really honored to be a part of that. So a lot of material here. This was quick. In summary, hopefully I've shed some light that it takes a village. My career has been made on through collaborations from many of our colleagues. I think there's still a way to go for the pharmacist scientist. NIH shows that 92% of funded scientists are PhD, makes sense. About maybe 7 to 8%, depending on where you cut the data, are more physician scientists. And of that, they're predominantly MDs. There's some MD PhDs. There's about 1 to 2% nurse scientists out there, few vet scientists, and the pharmacist scientists really didn't even make the cut. And this is old data from 2012, and I haven't been able to see anything since. So that really moves us to do a better job both highlighting and developing the pharmacist scientists, as we certainly have a lot to add to the scientific community. And I thank my fellows, and the 16 of them that I have had the honor of training throughout my career. All of them are still in the infectious diseases space. And right here is a list of, my village. Our president at URI says research is something you do with your friends. This is a list of all the people that I've had the honor to do science with and present with over the years. Although I really only touched on kind of the left-hand side of the screen here, there's many others and a lot of other research and outcomes and implementation science that, we just don't have time to talk about. So with that, I will end. I will stop sharing my screen. I think Sharon will join us and answer any questions.
Thank you so much. That was really spectacular. Really appreciate learning about the village. So I want to, we have some time for questions. I'd like to remind everyone, please enter your question into the chat, and I'm keeping an eye on it with the help of my friends. So I'll get started. And does your village include bioengineers?
Yes. So I have, I'm on an R01 with Ebru Oral at Harvard and Mass General, where we are looking at combination therapy. I'm looking at the combination therapy, and she is altering the topography of many prosthetic devices as a material scientist. So together we have certainly synergized. She sends us the chips and the materials, and we look at combination therapy, not only from an antibiotic therapy standpoint, but we'll combine different non-antibiotics in these type of models and look at the various changes in bacterial activity.
Okay, fantastic. Because obviously one would think that perhaps the composition of the prosthetic device might alter the biofilm production.
Yeah.
And I guess another, and by the way, there's a great interest amongst the bioengineers at both Brown and at the University of Rhode Island to collaborate with clinicians because it's those kinds of collaborations can be extremely productive.
I'll share, Sharon. Yes, we are working together. I didn't include that, but I'm working with several of the clinicians on the two still unfunded R21s and R01s we've submitted, but we are persistent, and I'm mentoring a couple of their early career scientists who will be submitting for a CTR pilot grant this cycle.
Good, good. And I guess another question is whether the village includes either natural product chemists or other chemists, because my understanding is that antibiotic development, it has slowed rather drastically. And I wondered if you could comment on that. And it seems that maybe 20 years ago, it seemed like every time I turned around, there was a new antibiotic hitting clinical use. And I haven't seen that many new ones recently.
Yeah, Sharon, you're exactly right. So to answer your question, yes, that is a whole other area of research that I've done with our colleagues here at URI, Dave Raleigh and Navindra Seeram, our chair, whose office is right next door. Lots of publications. I consider that their work that they have led, and I have just done the screening for them, but fantastic work in natural products and trying to identify new antibiotics. What has unfortunately happened in the antimicrobial development space, as we know, these bacteria have been around for 3.5 billion years, right? Us as humans, maybe only around 200,000 years, so like a blink of an eye. And these bacteria just rapidly develop resistance. And it's of my opinion, I'm sure industry colleagues will argue with this, is that we haven't had any new novel mechanisms of actions of antimicrobial agents recently. We're just taking the skeleton and the infrastructure of the antibiotics we have and altering them somewhat to evade whether it's a porin channel mutation or an enzymatic degradation. We're really struggling in developing new antibiotics. And these bacteria are quick and they develop resistance rapidly.
And do economics play a role in this?
Oh, that's a question. I have the honor usually every February to go to DC and meet with many different representatives and members of Congress to try and push for more funding in antimicrobial resistance research. I will say that there's always another need, whether there's, in the infectious diseases space, we need more money for tuberculosis and HIV and hepatitis and cancer, and we kind of get squished out a little bit. And there's different arguments on how, when the government has funded new antimicrobial discovery, they come to market and these antimicrobials sit on the shelf. They don't get used because, there's that mindset of being a good steward and to keep that on the shelf. And there's a huge cost associated with these new antimicrobials, $10 a dose versus a couple $1,000s to recoup that money. It does become a bit political.
Okay, so we have a interesting question from Attila Sehan, who's a cancer biologist, and he's asking about the tumor-specific microbiome. Intratumoral bacterial load has been shown to be associated with poor survival in patients with various cancers and was negatively associated with T lymphocyte infiltration. Notably, the tumor microbiome appears to be organ-specific. What are your thoughts about this for cancer treatment and to help developing new personalized medicines? In other words, maybe use these bacteria for a useful purpose.
Yeah. A fantastic question. And I had a couple slides on the microbiome work that we've been doing. We have a couple recent papers out there. Boy, that could be a whole other talk. So my quick response is yes. There is so much that we are learning about the role of the microbiome. Some consider it another organ that we haven't talked about, that really helps regulate not only the brain-gut axis from Alzheimer's to depression and anxiety, to cancer, to diabetes, obesity, allergies. 70% of our immune system really comes from interactions of biosis or dysbiosis in our gut. So yes, fantastic. And it would be fantastic to work together and do a better job merging our cancer and infectious diseases type of expertise.
And Hannah Wu asks, with regard to mechanisms of combination antimicrobial treatment, could you please comment on the role of the patient's immune response?
Oh, fantastic question, Hannah. Yes, that we model in our lab is these neutropenic environments where we really just have the drug and the bug. The next stage is we take this into animal models. We have others do that. We don't do the animal model work in our lab. And some of our proposed research in these RO1s and R21s that I was just talking about really is going to try to dissect the role of the immune response to augment the antibiotics response. So yes, if a patient has an immune response, usually there's an augmented activity, but that still needs to be dissected, especially in the biofilm space.
Okay, great. Well, we've reached the top of the hour. I want to thank you, Carrie, once again. Thank the Advance-CTR staff for their support, and thank all of our participants. This has been really a lot of fun, and we very much enjoyed it. Thank you.
Thank you so much.